the World Health Organization has issued a significant update regarding the transmission dynamics of the Andes strain of Hantavirus, confirming that this specific pathogen has demonstrated the ability to spread through human breath. This development marks a critical shift in the understanding of hantavirus epidemiology, which has traditionally focused almost exclusively on zoonotic transmission from animal reservoirs to humans. While most hantaviruses identified globally require direct or indirect contact with the saliva, urine, or feces of infected rodents, the Andes virus, primarily found in South America, has long been a subject of intense scrutiny due to its unique potential for person-to-person spread. This official confirmation by international health authorities underscores a transition from sporadic environmental exposure to a more complex public health challenge involving respiratory transmission between individuals. Viewers should understand that hantaviruses are a family of viruses spread mainly by rodents and can cause varied disease syndromes in people. In the Americas, these are typically categorized as hantavirus pulmonary syndrome, or HPS, a severe and sometimes fatal respiratory disease. The Andes strain is a member of the Hantavirus genus and is endemic to the southern cone region of South America, particularly within the border regions of Argentina and Chile. The confirmation of respiratory transmission, described as spreading through human breath, implies that the virus can be aerosolized or carried in respiratory droplets during close contact. This mechanism bypasses the traditional requirement for a rodent intermediary in every infection case, suggesting that clusters of the disease can form within households, healthcare settings, or social gatherings once an initial spillover event from a rodent occurs. This specific framing of the situation by the WHO serves as a global alert for clinicians and public health agencies to broaden their surveillance criteria. The significance of this finding cannot be overstated, as it necessitates a re-evaluation of how respiratory pathogens are monitored in regions where the Andes strain is active. Unlike the sin nombre virus, common in North America, which has no documented history of human-to-human transmission, the Andes strain's ability to move between people via the respiratory route places it in a different category of risk. This report examines the technicalities of this transmission, the official statements guiding the current response, and what this means for international health security moving forward. By focusing on the scientific mechanisms of aerosolization and the documented behavior of the Andes virus in clinical settings, we can better understand the gravity of the WHO's recent announcement without resorting to alarmism. The focus remains on the data-driven reality that while the primary reservoir for hantavirus remains the long-tailed pygmy rice rat, the human element of the transmission chain has now been officially solidified in the public record. Central to the current developments are the international and regional health agencies tasked with monitoring the spread of the Andes strain. Following the World Health Organization's confirmation, national health ministries in affected regions are intensifying their laboratory and clinical surveillance protocols. The core of the response involves high-security laboratory environments, typically biosafety level 4 facilities, where researchers study the viral load present in the respiratory secretions of infected patients. Data from these institutions indicate that the Andes virus can be detected in the breath of patients during the prodromal phase, the early period of symptoms before the full onset of pulmonary distress, and during the acute phase of the illness. This timing is critical for public health officials because it means an individual may be contagious before they are hospitalized, complicating efforts to contain local outbreaks. Testing protocols are also being updated, while RT-PCR remains the gold standard for identifying the viral RNA. There is an increased emphasis on contact tracing to identify anyone who may have inhaled viral particles in close proximity to a confirmed case. The WHO's statement contrasts with previous decades of hantavirus research that largely dismissed the possibility of significant human-to-human respiratory spread. However, verified information from recent clinical observations has forced a revision of these long-standing theories. In specialized clinics across the Southern Cone, medical personnel are observing cases where multiple members of the same family or social circle contract the virus despite having no shared exposure to rodent-infested environments. This clinical evidence, supported by molecular sequencing that shows near-identical viral strains within these clusters, provides the factual backbone for the WHO's confirmation. It is important to note that while the term human breath is used, the transmission is generally associated with prolonged and close contact, often in confined spaces. There is currently no evidence in the source material or official statements to suggest that the Andes virus has achieved the same level of high efficiency. Long-range aerosolization seen in common seasonal flus or other highly contagious respiratory viruses. Instead, the focus remains on the breath as a vector within immediate physical proximity. Official statements have been careful to distinguish between this documented human-to-human route and the broader environmental risks. Public health labs are now working to determine the duration of viral shedding in the breath of survivors, a key data point that remains largely unknown but is vital for determining quarantine and isolation periods. The logistical challenge for health systems involves ensuring that clinics in rural or remote areas have the diagnostic kits and transport media necessary to send samples to central labs quickly, as early detection is the only way to effectively manage the risk of secondary transmission. Prevention and public guidance regarding the Andes strain are now operating on two parallel tracks: traditional rodent control and new respiratory precautions. For decades, the standard advice for preventing hantavirus has focused on excluding rodents from homes, using disinfectants when cleaning areas where mice have nested, and avoiding the inhalation of dust in sheds or cabins. While these measures remain the primary defense against the initial spillover from the environment, the confirmation of respiratory spread between humans introduces a need for clinical-level precautions in the home and hospital. Public health agencies are now advising that anyone exhibiting the early symptoms of HPS, including fever, severe muscle aches, and fatigue, who has been in contact with a known patient, should be isolated immediately. The use of high-efficiency masks and eye protection is recommended for caregivers and healthcare workers to mitigate the risk of inhaling infectious breath particles. Despite these proactive steps, there are significant limits to current knowledge. The exact volume of viral particles required to initiate an infection via breath is not yet quantified, nor is the impact of environmental factors like humidity and temperature on the stability of the virus in the air. Surveillance remains the most potent tool in the global arsenal by tracking the genetic evolution of the Andes strain. Scientists hope to determine if the virus is becoming more adapted to human transmission, or if these respiratory events are simply a stable, albeit dangerous, feature of this specific strain. The official stance is one of vigilant observation rather than panic. Public health systems are urged to maintain high levels of suspicion in respiratory cases occurring in endemic regions, ensuring that atypical pneumonia is screened for hantavirus whenever appropriate. The goal of this enhanced surveillance is to prevent the Andes strain from moving beyond its known geographic boundaries through travel or trade, although currently there are no official restrictions on movement related to this announcement. As the global health community digests the WHO's confirmation, the focus remains on localized containment and the protection of the most vulnerable populations in South America. Honest reporting necessitates acknowledging that while the threat of respiratory spread is real and officially recognized, the number of such cases remains small compared to other global respiratory pathogens. This balanced perspective allows for the implementation of necessary safety protocols without triggering unnecessary societal disruption. We will continue to monitor official statements and laboratory data as they become available. For more updates on global health surveillance and emerging viral threats, consider following this channel for factual reporting. The core developments surrounding the Andes virus transmission shift are centered on the rigorous laboratory findings and clinical observations reported by the World Health Organization and regional health ministries. For decades, the Hantavirus genus was categorized almost exclusively as a zoonotic threat, with human infection acting as a biological dead end. However, the official confirmation that this specific strain is spreading through human breath necessitates a fundamental change in clinical diagnostics and hospital biocontainment. In specialized high-containment laboratories, molecular biologists are analysing the viral load present in the exhaled breath condensate of patients. These studies indicate that the virus can remain viable in respiratory droplets and fine particle aerosols generated during normal speech, coughing, or heavy breathing. This specific mechanism of transmission distinguishes the Andes virus from its North American counterparts, such as the sin nombre virus, which lacks this documented human-to-human capability. The data suggests that the viral shedding begins during the late prodromal phase, characterized by non-specific symptoms like fever and myalgia, often before the patient develops the catastrophic respiratory failure associated with Hantavirus pulmonary syndrome. This creates a critical window of vulnerability where unsuspecting contacts may be exposed. National health agencies in the Southern Cone, particularly in Argentina and Chile, have been working in coordination with the Pan American Health Organization to map these transmission chains. Laboratory protocols now emphasize the use of real-time polymerase chain reaction, or RT-PCR, to detect viral RNA in respiratory swabs rather than relying solely on blood serum or tissue samples. The logistical challenge presented by this development involves the rapid deployment of these diagnostic tools to rural or underdeveloped regions where the virus is endemic. When a cluster of cases is identified, hospitals must now implement strict isolation protocols that mirror those used for other highly infectious respiratory pathogens. This includes the use of negative pressure rooms and N95 grade filtration for all attending staff. Clinical data from these facilities show that the Andes virus induces a rapid inflammatory response in the lungs, known as a cytokine storm, which leads to increased capillary permeability and pulmonary edema. The confirmation of breath as a vector suggests that medical personnel and family members are at a higher risk than previously calculated. Furthermore, the World Health Organization's move to categorize this as a confirmed respiratory threat highlights the importance of genomic surveillance by sequencing the viral genome from different clusters. Researchers are attempting to determine if a specific mutation has increased the virus's affinity for human respiratory cells, or if the breath transmission is a long-standing trait that has only recently been definitively quantified. Current evidence indicates that while the virus is not as broadly transmissible as common seasonal viruses, the high case fatality rate, often exceeding 30%, makes even small-scale respiratory clusters a major public health priority. Official reports remain focused on the localized nature of these outbreaks, typically occurring in remote mountainous or forested areas. But the human breath vector introduces a variable that could theoretically facilitate spread through travel hubs if an infected individual enters the acute phase while in transit. Surveillance at the primary care level is being bolstered, with officials urging clinicians to maintain a high index of suspicion for any patient presenting with rapid onset respiratory distress who has been in proximity to a confirmed case. The limitations of current data are also being transparently addressed by health agencies. Specifically, the exact duration that the virus remains infectious in an aerosolized state remains a subject of ongoing investigation. This uncertainty dictates a conservative approach to quarantine and the management of recovered patients, who may continue to shed viral markers after their clinical symptoms have subsided. In light of the confirmed respiratory transmission of the Andes strain, public health guidance is undergoing a strategic expansion that bridges traditional environmental hygiene with modern respiratory precautions. For decades, the foundational pillar of hantavirus prevention has been the mitigation of zoonotic risk, specifically targeting the interaction between humans and the long-tailed pygmy rice rat, the primary reservoir for the virus in the Southern Cone. Practical takeaways for individuals in endemic regions, or those travelling to these areas, remain centred on strict rodent exclusion. This involves sealing any openings in dwellings larger than a pencil's width, as rodents can compress their bodies to enter surprisingly small gaps. Officials emphasise that when cleaning potentially infested areas, such as seasonal cabins, sheds or storage units, dry sweeping or vacuuming must be strictly avoided. These actions aerosolise dried rodent urine and faeces, creating a cloud of infectious particles that can be easily inhaled. Instead, the current protocol dictates that surfaces should be thoroughly wetted with a disinfectant solution, typically a mixture of 1 part bleach to 9 parts water, and allowed to soak for several minutes before being wiped down with paper towels or rags, while wearing rubber gloves and, ideally, a high-efficiency particulate respirator. However, with the WHO's confirmation of human-to-human breath transmission, a second layer of prevention is now necessary. Public health agencies are advising that anyone who has had close contact with a confirmed hantavirus patient must monitor themselves for symptoms for at least 45 days, which is the upper limit of the known incubation period. If symptoms such as high fever, muscle aches, or sudden shortness of breath occur, immediate medical evaluation is required, and the individual should inform healthcare providers of their specific exposure to the Andes strain. In domestic settings where a family member may be incubating the virus, increasing ventilation by opening windows and using air purifiers with HEPA filtration can reduce the concentration of respiratory droplets in shared spaces. For healthcare providers, the transition to respiratory precautions means that the Andes virus is no longer treated solely as a contact-based or environmental threat. Facilities are being instructed to use full personal protective equipment, including N95 masks and eye protection, for any procedures that might generate aerosols, such as intubation or nebulizer treatments. The surveillance aspect of this response is equally critical and involves a massive international data sharing effort. Health agencies are not only tracking human cases, but are also conducting environmental surveys to monitor the prevalence of the virus within wild rodent populations. This sentinel approach allows officials to issue early warnings when the viral load in the environment reaches a threshold that increases the likelihood of a spillover event into the human population. Despite these robust efforts, significant limits to our knowledge remain. The scientific community has yet to determine the exact infectious dose required to cause disease through breath alone, nor is it fully understood how long the virus remains stable in an aerosolized form outside the human body. Furthermore, while the Andes strain is the only hantavirus currently confirmed to spread this way, the discovery has prompted a global review of other orthohantaviruses to ensure that similar transmission paths are not being overlooked elsewhere. The ethical responsibility of public health reporting in this context is to balance the gravity of the disease's high mortality rate with the factual reality of its current geographic and statistical reach. While the confirmation of respiratory spread is a serious development, it does not imply a global pandemic on the scale of more common respiratory viruses. The Andes virus remains a rare, geographically localized pathogen, and the primary risk remains tied to specific environmental and social exposures. By providing clear, data-driven guidance, authorities aim to empower the public through informed caution rather than fear. As research continues into the molecular mechanisms of this breath-based transmission, the focus will stay on rapid detection, early clinical intervention, and the maintenance of rigorous hygiene standards. We will continue to track the official statements and clinical data as they evolve to provide the most accurate updates on this emerging public health challenge. To stay informed on global health surveillance and the science behind viral transmission, consider subscribing for continued factual coverage.